Next is Plafond fractures by Dr. Graham McCollum.
Good morning, everybody. Thanks for hanging in, and I'll try and enlighten you a little bit. So, Plafond fracture is extremely complex, difficult to treat with unpredictable outcomes. Sorry. So the two main Plafond fractures, high energy Plafond fractures and low energy Plafond fractures, which are more rotational, and the high energy, more axial load impaction fractures. Dussault, the French radiologist, was the first to coin the term Plafond fracture after a mortar and pestle grinding instrument to crush herbs and pepper. By definition, it's an intra-articular fracture of the distal metaphysis, usually with axial load in a varying position of the foot. So in preparing this talk, I just went through my series over the last 3.5 years, both in government and in private, and I did managed 63 Plafond fractures over this period. 52 of them had a temporary external fixator, 48 had a formal ORIF, so I've obviously got a bit of a plating bias, and then the rest, there are 6 limited ORIF and external fixator. There were 5 deep infections, and infection rate similar to what's reported in the literature, bearing in mind that some of my patients weren't really in a high socioeconomic bracket, and following them up for about 36 months now. So what are the aims in managing these fractures? Obviously, it's to avoid deep infection, to attain union, maintain anatomical alignment, reconstruct the joint, and provide early range of motion. But this is not always achievable. If you've ever managed these before, you'll know. There's been an evolution in management of these fractures. Initially in the 1950s, people began to reduce them, open and internally fix them, but that was fraught with complications back then. And then Rudy and Algar came up with their 4 principles of open reduction and internal fixation immediately. And early complications in the 1980s showed that perhaps limited internal fixation and external fixation showed lower complication rates. And now we've got a range of different techniques and different ways of treating these fractures in our armamentarium. Jorgensen was the first to apply a cast, and he said these fractures were not amenable to surgery. But Rudy and Algar refuted this, saying in 84 Plafons that they had really quite good results, but we know that these were low energy injuries and not reproducible in further series. They did another study in 1978, a multi-center study, and had astonishingly good results. I don't know, obviously they're better than us, or they have lower energy fractures. And they came up with a classification that we commonly use today. And then the AO classification, which is useful for reporting results and for research, but practically what it boils down to is what you see on your scan and what you plan for. Ovadia and Beals also said that early ORIF had much better results than other modalities, such as casting and external fixators. And they managed 145 cases. And Tile and Schatzke also said that you should do an immediate ORIF. But this led to a large number of problems as seen by Tini and Wiss, with up to 50% deep infections in their series. And McFerrin reiterating this and led to a number of other treatment modalities. Bow and Tonetta also showed that their spanning with limited internal fixation had much lower complication rates, and Sirkin was the first to introduce staged open reduction internal fixation, X-fix initially, and then stage the ORIF later. And MIPO techniques have also shown lower infection rates, but higher non-union rates. I think that's probably because of locking and making these fractures too stiff. So looking at these fractures and managing them, there are a couple of things that we are in control of, and that's really just our surgical skills, but all the others we don't really have too much control of, and they all have to be taken in cognizance when managing these fractures. There are obviously fracture patterns, soft tissue injuries, and then there's patient factors. So the main controversies in managing these fractures, I think, is obviously the timing of the surgery. Even though stage management is what we advocate, there's still some surgeons who operate on these immediately before the blisters come out. There's just been a JBJS paper that's showing that they have good results with immediate surgery. The methods of fixation, there's a large armamentarium of things that are disposable. Whether to plate the fibula, when, and surgical strategies, and there seems to be a wide range in outcomes and complications reported. So these are the sort of techniques and strategies that we have in managing these fractures, and it gets a little confusing. Sometimes it's unclear in the literature which is better or what favors what is the best technique, but often it boils down to surgeon preference, and there's a lot of selection bias in a lot of the literature. And there's no real evidence in randomized controlled trials to suggest one treatment over the other. What about plating the fibula? I think it's controversial whether to plate the fibula at the time of the injury or not. It does provide immediate stability and length. In this particular fracture, it was a highly complex metaphyseal fracture extending into the plafond, with difficulty in maintaining stability just with the ankle spanning external fixator. So the fibula was plated. The downside is that there's potential for infection. If you don't get it perfect, then you can malreduce the Chaput fragment or the distal tibia, and it might compromise your approaches further down the line. Looking at the literature, it's very divided, and there's only, at best, level 3 evidence to suggest whether we should be plating the fibula at all. Recent study in 2015 showed that it made no difference in plating the fibula if you performed lock plating of the distal tibia at the time. So my approach with the fibula fracture at the time of the injury, whether to address it at the initial spanning external fixating session, if it's quite a high fibula fracture, if the incision is going to be away from further from your incisions for the distal tibia to reconstruct the box. If the soft tissues are amenable, of course, and if there's a diastasis or a syndesmotic disruption, it does complement your external fixator stability. And I don't advocate it in complex distal fibular fractures where you're going to spend time and you're going to be a soft tissue dissection, but a simple 6-hole semitubular plate here can add 20 minutes to your operation and probably add some stability to that. So I would say, in my opinion, plating the fibula at the initial setting is controversial. I would just select it in those type of fractures. But just a word on external fixators and pilon fractures. Not every pilon fracture needs to have an external fixator. This is just a simple anterior compression fracture. Of course, if it was open or if there were massive blisters, I might reconsider that, but this does not need an external fixator. There's a morbidity to external fixators, but they're certainly useful when necessary. If there's impaction and shortening, if there's gross soft tissue involvement or energy through the soft tissues, then it's necessary. There are a number of different techniques to span the ankle, and this is just showing that this one on the left probably doesn't need an external fixator. This one certainly does. What we have been doing recently is spanning the ankle using 2 crossed pins through the heel, just distal to the Achilles tendon insertion. The advantage to this is you can spare the heel from compression on the bed. You use a U-bar here. You can control the equinus, and with crossbars here, you can make it really fairly stable, and you manage the soft tissues there. And at the time of the surgery, you can leave the pins in. These pins have so fewer pin track problems compared to the delta frame or the transcalcaneal pin. And in theatre, even we've left them on and used them as part of the femoral distractor. The transcalcaneal pin or the delta frame is what's advocated and what the AO teach. But there are some structures at risk, and I've seen a number of patients with injury to the medial plantar nerve, lateral plantar nerve, calcaneal nerve. So you have to be pretty accurate. And if you're going to do that, then start on the medial side and put your pin from medial to lateral blunt dissect, because when you go from lateral and come out blindly on the medial side, these structures are injured. But the delta frame is certainly very quick and easy to put on. As with all orthopedic operations, periarticular fractures need meticulous planning, and a CT scan is mandatory. You can see in this fracture here, it looks fairly benign, but the CT scan shows that there's a flipped piece in the back. I like the axial view and the sagittal views, coronal views are very important to plan what you're going to do. Tornetta showed that up to 64% of surgeons actually changed their surgical plan once they'd seen a CT after the X-ray. Another caution when planning your surgery, and if you're planning an internal fixation, is to know the length of the fracture and the length of the plate you're going to need. I've been snookered a couple of times where our plate hasn't quite been long enough, or the longest plate is too long and the next length of plate is too short. So you really got to plan ahead and know what lengths plates these companies have. The most common incisions that I use, and I said I've got a bit of a plating bias, but I do from time to time use fine wire fixators or hybrids, but still you need to reduce the box, and these incisions are useful. The most common is a medial for that medial fragment, anterolateral, and direct anterior. The posterolateral is very useful, and the posteromedial for those medial malleolar fractures where there's a flipped piece there. I like the axial view, just to look at these very consistent fragments, the anterior fragment, the medial, the posterior, and then the die punch fragment, which is usually accessible through the gap between the medial and the anterior fracture. So what I find quite useful is to identify the columns. So I know that I'm going to really have a tough time when both columns are fractured, if it's fractured at the front and the back, like in this case, because usually that means dual approaches, and positioning of the patient is important. When it's just a single column fracture, then I know I've got something to build onto, and it's a much more pleasant operation where the patient just stays in one position. So that for me is even more useful than just classifying according to Rudy and Algar. You can see from this case here is a simple anterior column fracture, one single incision and an anatomical reduction. Whereas this case here, you could see that there was a large posterior component and a medial component, but the anterior column was intact, so I could address both the fibula fracture and the posterior malleolar fracture through a posterolateral incision and then a medial incision to reduce the medial malleolar fracture. There's another case of just a posterolateral approach where the fibula was addressed at the same time as the posterior malleolar fracture, and that flipped piece was inverted and reduced anatomically. He's back playing tennis now. And then you have these scary moments when there's peri-prosthetic fracture or peri-implant fracture. This is a competitive jockey, one of the top jockeys in the country, obviously a previous ORIF. A lot of comminution there in the corner. These are axial loads under varus strain or varus load, requiring a medial and an anterior approach. You can see the front is blown out here, so two small incisions and an anatomical reduction, and he's back on the horse. Similar approach here, a guy for rock climbing with a medial shear type pilon. You can argue that this is a Weber A type fracture, but I think when it involves a lot of the Plafond there, this is, in my book, a Plafond fracture or a medial shear injury treated with a single medial incision. So you've got to be quite versatile when planning for these operations. This is a gentleman who came from a skiing accident. He put in a temporary external fixator in Switzerland. He didn't fancy the Swiss surgeons flew back. He had dodgy pin tracts and enormous swelling, so I didn't fancy putting a long plate in him, so we planned to do a limited open internal fixation with 3 cannulated screws. Planned to have an olive tip wire to reduce the medial malleolus, and had a foot frame on for 6 weeks, which was removed, and then he walked around for another 6 weeks, and the frame was taken off for 3 months. Slight anterior tilt, but excellent range of motion. He's booked his skiing trip for next year. And another axially loaded fracture. I get some fractures managed at the day hospitals or other referral centers that come to us in a delayed setting. This patient certainly should have had an external fixator. Gross shortening. I planned the surgery to have 3 incisions. The soft tissue was amenable, and I needed to address all of those fragments. There was no way ligamentattaxis was going to do this at 2 weeks after the injury. I like what I term fracture-specific addressing and fixation with these 3 incisions, similar to what they're doing in the wrist, and with a reduction of all 3 of those fragments. I used a posterolateral approach, a medial approach, and a small anterolateral approach. And then first reconstructed that posterior column just with a single DCP, medial approach, and reduced the medial malleolus, and a small anterior approach, all quite small incisions, bearing in mind the soft tissues. But it doesn't always go that well. There's one disaster case which required a flap, which became septic, and metal failure and a septic non-union. Some are not reconstructible. This case here came to our clinic after being at a referral hospital, bad anterior soft tissues. I said there was only one way to do this, and it was an acute fusion. This is a philos plate, proximal humerus plate. I got fixation into the calcaneus, didn't prepare the subtalar joint, removed the plate at 6 months, and he is fully united, walking around quite well. The subtalar joint's preserved, and at least he's got his foot. So we look at the literature. These authors reiterate the severe injury. Most patients are limited. Those that have a bad reduction have poorer outcomes. It seems that if you're divorced, if you have low income, if your education level is low, and if you're a compensation seeker, your results are poor. These other authors show that over time, these pilon fractures do tend to improve, so don't rush in and do a fusion at 6 months or a year. They sometimes settle, and even though they look terrible, the radiological findings don't bear out clinically, so wait at least 2 to 3 years before you go on to do some sort of reconstruction. Respect the soft tissue span, delay the RF. These are multifactorial issues that you have to deal with, and factor them all in. Use tools that you're used to. If you're a framer, then do it well. And complications are inevitable with these fractures. Obviously, try and limit them. Thank you.
Thank you, McCollum.